Welcome to the deep dive. You might have noticed a cloudiness in your dog's or cat's eyes before, and today we're going to unpack exactly what's going on beneath the surface of that hazy look.
Mm-hmm.
We've gathered some really interesting information about corneal opacities,
Yeah.
that milky or cloudy appearance on the eye's surface.
Right.
What's fascinating is that this isn't just one simple issue. There can be, well, a variety of different reasons behind it.
Exactly. When we talk about corneal opacity, we're describing any loss of that normal, clear transparency of the cornea, the protective outer layer of the eye.
Okay.
Our sources today point to three main categories of problems that can lead to this cloudiness: corneal degenerations, corneal dystrophies, and a condition we see primarily in cats called corneal sequestrum.
Three main types then.
Yes. So we're looking at acquired issues, inherited conditions, and a rather unique feline response.
Okay, let's unpack corneal degenerations first. Our information indicates that these are typically acquired conditions.
That's right, acquired, meaning they develop during an animal's lifetime.
Not born with it.
Exactly. And they often involve deposits building up. We're talking about either lipids, those are fats, or calcium.
Fats are calcium. And it seems this is more common in dogs, particularly older dogs.
Yes, more common in dogs, especially geriatric ones. And what's key to understand about corneal degeneration is that it's often a sign that something else is happening,
Ah,
either directly in the eye or, elsewhere in the body.
right. So what do these lipid deposits look like?
Well, when we see lipid deposits, they can have a gray, white, or even a sparkling crystalline appearance.
Crystalline, like little sparkles.
Yeah, sometimes quite sparkly, and the shape can vary quite a bit.
Mm,
Sometimes they're in bands, other times irregular patches, or even complete circles.
interesting.
The sources highlight that if these lipid deposits are linked to high levels of fats in the bloodstream, a condition called hyperlipoproteinemia.
Hyperlipoproteinemia. Got it.
You might even observe a ring around the very edge of the cornea. It's called arcus lupoides cornea. There's usually a subtle clear zone right at that outer margin, too.
So linked to fat metabolism issues.
Often, yes. Disruptions there are frequently at play.
Now, calcium deposits sound quite different. Our sources describe them as dense white, almost chalky.
Yes, dense white, almost chalky, or again, sometimes crystalline. These lesions tend to be irregular in shape or form, distinct bands, usually in the more superficial layers of the cornea.
Okay?
And the really interesting point here is the strong connection to inflammation inside the eye, things like keratitis or uveitis.
Inflammation.
And it appears that when calcium is involved, you're also more likely to see new blood vessels growing into the cornea.
Vascularization.
Exactly. Along with some swelling, corneal edema, and even pigmentation sometimes.
And can it get worse?
It can. If this progresses, the smooth surface of the cornea can become rough and in some cases lead to painful ulcers. Really underscores how interconnected the eye's health is.
It really does.
Absolutely. And if we think about the broader context, our sources provide quite a list of other eye issues that can actually predispose an animal to this corneal degeneration.
Oh, really? Like what?
Well, we're talking about things like pre-existing stars on the cornea, dry eye syndrome, KCS,
All right. Right.
exposure keratitis, where the eyelids aren't fully protecting the eye, chronic internal inflammation, so uveitis again, even a shrinking or non-functional eye, that's phthisis bobae, prolonged use of steroid eye drops.
Ah, steroids.
Yes, and even tumors located at the limbus, that junction between the clear cornea and the white sclera.
Wow. Quite a list. It emphasizes that these degenerations don't usually happen in isolation then.
Precisely, they're often secondary.
So what's actually causing these deposits to form? For the lipid ones, you mentioned hyperlipoproteinemia.
That's the main factor, yes. Those elevated fat levels in the blood. And the sources give us a breakdown of potential underlying causes for that.
Okay.
It ranges from primary genetic predispositions, like in miniature schnauzers,
Right.
to secondary issues, things linked to conditions like hypothyroidism, diabetes, Cushing's disease,
Okay.
even something as common as a pet getting into rich, fatty foods, dietary indiscretion, or more serious conditions affecting the pancreas, kidneys, and liver.
So it could be systemic. A wide range of possibilities impacting fat metabolism.
Definitely. And when we look at calcium deposition, the potential culprits often involve disruptions in the body's calcium and phosphorus balance.
Okay, like what?
This can include a genuinely high levels of calcium or phosphate in the blood, maybe excessive vitamin D. Cushing's disease again pops up,
Yeah.
kidney failure, so uremia, and even simply the aging process in older animals.
So just getting older can be a factor.
It seems so. And the sources also make a crucial point. It's not uncommon to see both lipid and calcium deposits occurring together in the same cornea.
Both at once. Interesting.
Yeah.
Now, if you see a cloudy eye, how can you tell if it's one of these degenerations and not something else entirely? Our sources mention differentials.
Yes, differentiating is key. For example, a simple corneal scar is usually smooth, non-painful, has distinct edges, and importantly, it won't retain that fluorescein dye we use to check for ulcers.
Fluorescein negative. Okay.
Then there are corneal stromal dystrophies, which we'll get to, but they're typically bilateral, symmetrical, and not linked to inflammation.
Right.
Edema, or corneal swelling, tends to have a more bluish-gray, hazy look with kind of indistinct margins.
Blurry edges.
Exactly. And of course, a corneal ulcer itself will be painful, and it will stain brightly green with fluorescein dye.
Right. The stain picks it up.
And finally, inflammatory cell infiltrates are also painful and have a more gray, tan, or even yellowish look. Cytology might show white blood cells, so appearance and other signs help tell them apart.
That makes sense. So this brings up an important point. When do vets need to do more in-depth systemic testing, blood work and such?
Our sources indicate it's primarily when they suspect those elevated levels of lipids or calcium in the bloodstream.
Okay, so if the deposits look fatty or chalky,
Pretty much. So blood tests looking at cholesterol, triglycerides, blood glucose, calcium, phosphorus, those would likely be recommended.
Basic blood panel.
Yeah, and depending on those initial findings, further tests might be needed. Maybe assessing thyroid function, adrenal gland function for that Cushing's connection, or even pancreatic health tests like PLI.
got it. And looking directly at the eye again, our sources note that the fluorescein dye might actually get trapped around the raised edges of the deposits.
That can happen, yes. It doesn't mean there's a true ulcer through the deposit, but the stain can pool around it if it's raised.
Okay, so how do we approach treating corneal degeneration?
Well, the initial step usually involves addressing any primary eye conditions contributing to it, like treating that dry eye or uveitis first.
Makes sense. Treat the underlying eye problem.
Right. If high blood fats are a concern, a low-fat diet is often a key recommendation. And naturally, treating any underlying systemic disease is paramount.
Like the hypothyroidism or Cushing's.
Exactly. Now, if the deposits themselves are causing the animal discomfort or significantly impacting vision,
Then what?
then surgical removal might be considered. This could involve gently scraping away the deposit's debridement or performing a superficial keratectomy.
Which is removing the outer corneal layer.
Yes, removing that affected outer layer. However, the sources caution that these deposits have a high likelihood of returning if the underlying cause isn't effectively managed.
Ah, so surgery isn't always a permanent fix.
Often not, unless you fix the root cause.
What about medications? Eye drops.
Sure. It sounds like if a corneal ulcer is present along with the degeneration, broad-spectrum antibiotic eye drops would be used.
Standard ulcer treatment.
Yes. If there's inflammation inside the eye, like uveitis, then topical non-steroidal anti-inflammatory drugs, NSAIDs, might be prescribed.
Okay.
Cyclosporine eye drops can sometimes help improve tear film quality and reduce inflammation too. Atropine can be used short-term to alleviate pain associated with uveitis or ulcers.
For comfort.
Right. And for calcium deposits specifically, there are topical EDTA eye drops. EDTA chelates or binds the calcium. It works best after some of the deposit has been physically removed or debulked.
EDTA for calcium.
And simple artificial tears can provide lubrication and help prevent ulcers if the corneal surface is irregular from the deposits.
Just supportive lubrication.
Exactly. But it's also really important to know what not to use.
Oh. Contraindications.
Yes. Our sources specifically warn against using topical corticosteroid eye drops.
No steroids. Why?
They can actually worsen the severity of corneal degeneration, especially lipid deposits, and they are absolutely contraindicated if there's any ulcer present. They prevent healing.
Okay. Big warning there. No steroids.
Definitely. Additionally, atropine should be avoided in animals with pre-existing dry eye glaucoma or if the lens of the eye is displaced, luxated.
Got it. Other considerations.
Regular monitoring of those serum lipid levels and ongoing management of any identified primary diseases are also crucial for long-term care.
So what's the overall outlook? The prognosis?
Well, our sources indicate there's a potential for corneal ulcers to develop or worsen over time if the surface is rough. Vision can be affected in more advanced cases or if there's a significant concurrent primary eye disease.
And their recurrence.
And yes, even after surgical intervention, those pesky deposits have a tendency to recur if the underlying issue persists.
Right, need to manage the cause. Okay, let's move on now to corneal dystrophies. How are these different from degenerations?
Okay, so unlike degenerations, corneal dystrophies are considered primary conditions,
Primary meaning.
meaning they aren't caused by another underlying disease. They are typically inherited.
Ah, genetic.
Yes, usually inherited, typically affect both eyes,
Bilateral.
often in a symmetrical way, and crucially, they aren't associated with any other systemic or ocular problems like inflammation.
So, standalone, inherited, bilateral cloudiness.
That's a good summary.
Yeah.
And our sources categorize them based on the specific layer of the cornea that's affected. The epithelium, the stroma, or the endothelium.
Outer, middle, inner layers. Okay. Starting with epithelial dystrophy.
Epithelial, the outermost layer. Our sources highlight Shetland sheepdogs as a breed with a higher predisposition.
Shelties.
Yep. The onset is usually between 6 months and 6 years of age, and it tends to progress quite slowly.
And what does it look like? Signs.
The clinical signs can be very subtle. Sometimes there are no obvious symptoms, but in other cases you might see some squinting or excessive blinking, blepharospasm.
Oh.
On close examination, you might see multiple small white or gray, circular or irregularly shaved cloudy spots, sometimes even ring-like opacities. Occasionally, these can be associated with superficial corneal erosions.
So little surface ulcers.
Erosions, yes. But interestingly, vision is usually not significantly affected.
Good to know. What causes it?
The underlying cause for epithelial dystrophy is believed to be degenerative or possibly innate abnormalities affecting the corneal epithelium itself and the basement membrane right beneath it.
Okay. What about stromal dystrophy, the middle layer?
Right, the stroma. Our sources indicate this typically appears in young adult dogs, and there's a considerable list of breeds that can be affected. Afghans, beagles, huskies, cavaliers, quite a few.
Many breeds is the inheritance known.
What's interesting is that the specific mode of inheritance is only well established in a few of these breeds.
Okay. And the key feature of stromal dystrophy?
The key feature is that it's usually asymptomatic, no pain, no inflammation.
Just cloudy.
Pretty much. The most common presentation is a central stromal dystrophy. Here you'll see a gray, white, or silver oval or circular opacity located in the center or just off-center of the cornea. If you look closely with magnification, it might even have a sparkling crystalline appearance or maybe a hazy ground glass look.
Crystalline again, like the lipid degeneration.
Similar appearance, sometimes yes, but the cause and nature are different. This is dystrophy, not degeneration.
Got it. Any other types of stromal dystrophy?
Yes. Airedales are known to sometimes develop a more diffuse, widespread opacity throughout the stroma, and Siberian Huskies can get an annular form. Annular.
Like a ring, a donut-shaped opacity in the outer peripheral part of the cornea.
A donut, okay. Does stromal dystrophy affect vision?
Generally, vision is not impacted, although it's possible to see some visual deficits in very advanced or diffuse cases, but usually not.
What's the cause here? Still lipids.
It's thought to be either an inherent abnormality in the corneal tissue itself or maybe a localized issue with how the cornea processes lipids right there in that spot.
Localized metabolism issue.
Potentially. It's also been suggested that high levels of fat in the blood, that hyperlipoproteinemia, again, might potentially worsen the appearance of these opacities, but it doesn't cause the dystrophy itself.
It can modify it, but not cause it.
Exactly. Lastly, we have endothelial dystrophy, the innermost layer.
Okay. Endothelial. Who gets this?
Our sources say this primarily affects breeds like Boston Terriers, Chihuahuas, and Dachshunds. It typically appears in middle age to older dogs, and there might even be a slightly higher incidence in females.
Bostons, Chihuahuas, Dachshunds, older dogs, cats. Less common in cats, but it has been observed sometimes in young domestic shorthairs. And Manx cats have a somewhat similar inherited condition that affects the cornea, though it's not specifically endothelial disease in their case.
Okay. How does endothelial dystrophy present?
In the early stages, it might not cause any noticeable signs, asymptomatic early on. However, the hallmark of this condition is corneal edema, swelling.
Swelling. Okay. Where does it start?
It often starts in the temporal or inferiotemporal part, that's the outer lower part of the cornea, and then gradually spreads to involve the entire cornea. This can take months or even years.
Whole cornea gets cloudy and swollen.
Yes, eventually. And the sources mention the development of corneal epithelial bullae.
Bullae, like blisters.
Exactly, like tiny fluid-filled blisters on the surface. These bullae can rupture, leading to painful erosions or ulcers. That's when you see the squinting and discomfort.
Ah, so this type can become painful.
Yes, definitely, if those bullae ruptures. And in more advanced cases, vision can certainly be significantly impaired because of the widespread swelling.
What's the underlying problem here?
The fundamental problem is a degeneration of the endothelial cell layer, which is on the very back surface of the cornea.
The pump cells.
Precisely. These cells are responsible for pumping fluid out of the cornea to maintain its clarity. When they degenerate and don't function properly, fluid accumulates, leading to the swelling, the edema.
The pump fails, cornea swells up. Got it.
That's the mechanism.
So when diagnosing these dystrophies, what else do vets need to consider? Differentials.
Good question. For epithelial and stromal dystrophies, we need to rule out things we've discussed. Corneal degenerations, ulcers, scars, inflammatory infiltrates.
Okay.
For endothelial dystrophy, where the main sign is that diffuse swelling, the primary differential diagnoses are other conditions that cause widespread corneal edema, namely uveitis, that internal inflammation, or glaucoma, high pressure inside the eye.
Uveitis or glaucoma. Important rule-outs.
Very important. And as we mentioned earlier, while high cholesterol and triglycerides might influence the appearance of epithelial and stromal dystrophies, they aren't considered the primary cause of these inherited conditions.
Right, they don't cause it. Any specific tests? Fluorescein again, pressure checks.
Yes. Stromal dystrophy typically does not retain the fluorescein stain.
Say negative.
Usually. However, epithelial and endothelial dystrophies might retain stain, particularly in more advanced stages, or if those secondary erosions or ulcers from bullae have developed.
Okay.
And measuring the intraocular pressure using tonometry is crucial, especially with endothelial dystrophy, to rule out glaucoma as a cause or contributor to the corneal swelling.
Gotta check that pressure. Makes sense. How about treatment for dystrophies?
Treatment really depends on the specific type and how severely it's affecting the animal. Advanced cases of epithelial or endothelial dystrophy that have developed ulcers will require treatment specifically aimed at resolving those ulcers. Standard ulcer care.
Treat the ulcer first.
Right. For stromal dystrophy, in most cases, no treatment is actually necessary.
No treatment. Why not?
Because it's typically non-painful and doesn't significantly affect vision. Surgery to remove severe lipid deposits in stromal dystrophy is possible, but often not needed, and again, the opacities can recur.
Okay.
It's also very important to inform pet owners if a particular corneal dystrophy is known to be inherited in their breed. Responsible breeding advice.
Good point. What about the more severe endothelial dystrophy?
For advanced endothelial dystrophy, treatment options are more involved. They can include therapeutic soft contact lenses to protect the surface and make the eye more comfortable.
Bandage lens.
Kind of like that, yes.
Yeah.
Surgical procedures like a conjunctival flap can be done to provide support and blood supply. Thermal cautery, using heat to create small scars, can sometimes help reduce swelling.
Thermal cautery. Interesting.
Yes, a technique. And even corneal transplantation, penetrating keratoplasty, is an option, although the success rates for this can be variable in animals.
Corneal transplant. Wow. Complex. Any specific medications?
Well, like we said, if corneal ulcers develop secondary to any dystrophy, topical antibiotics and possibly atropine for pain might be used.
Standard stuff.
For epithelial dystrophy specifically, topical cyclosporine eye drops can sometimes help manage associated discomfort or erosions.
Cyclosporine again.
And for endothelial dystrophy, there's a specific ointment, 5% sodium chloride. It's hypertonic.
High salt concentration.
Exactly. It can be used as a palliative measure to help draw excess fluid out of the cornea, potentially reducing the edema and maybe preventing those painful blisters from rupturing as often.
Helps pull the water out. Palliative, though.
Mostly palliative, yes. Steroid eye drops are generally not considered beneficial for stromal dystrophy, and their use is questionable for the other types. Not really a go-to.
Okay. What about follow-up?
Follow-up for corneal dystrophies is primarily indicated if the animal develops pain or corneal ulceration.
Only if problems arise.
Generally, yes. The appearance of the opacity and lipid-type stromal dystrophy might fluctuate somewhat over time, wax and wane, but it's unlikely to completely disappear.
Right.
Ulceration, as we noted, can occur as epithelial or endothelial dystrophy progresses, and while vision is usually relatively good, it can become significantly affected in advanced cases of endothelial dystrophy due to that severe edema.
Okay, that covers dystrophies well. Now let's shift our focus to a condition that is almost exclusively seen in our feline companions, corneal sequestrum.
Ah, yes, the sequestrum, very characteristic in cats.
Those distinctive dark spots we sometimes see on cats' eyes. Our sources describe a corneal sequestrum as a very localized area on the cornea that develops into a light brown to black plaque-like lesion.
Right, a focal plaque. It's actually an area of stromal coagulation necrosis.
Necrosis, dead tissue.
Essentially, yes. The corneal tissue, the stroma, in that specific spot has essentially died and become opaque and pigmented. It's most often found in the central or just off-center part of the cornea.
Axial or paraxial.
Exactly. And it's also known as keratitis nigrum.
Nigger meaning black.
Yes, literally means black inflammation of the cornea.
Which cats get this? Any breed.
It can affect cats of any breed or age, but our sources do note that certain breeds seem more prone, particularly brachycephalic breeds.
Flat-faced cats.
Yes, like Persians and Himalayans. Also, Siamese cats seem predisposed. There's even a suggestion of a potential genetic link in color point cats.
Interesting. What does it look like over time?
The appearance can vary depending on how long the sequestrum has been present. It might start as a more translucent golden brown color
Golden brown early on.
and then become a dense, opaque black over time as it becomes more chronic. It's frequently associated with a chronic corneal ulcer that just doesn't seem to heal properly underneath or around it.
A non-healing ulcer often goes with it.
Very often. And you'll frequently see new blood vessels growing into the cornea towards the plaque and some degree of corneal swelling or edema around it.
Okay. Any other associated factors?
There's also a strong association with a history of feline herpes virus 1 infection, FHV1.
Herpes virus.
Right.
What might the owner notice?
Owners might notice their cat squinting, having some eye discharge, maybe tearing or thicker discharge. The conjunctiva might be red and swollen, and the pupil in the affected eye might be smaller than normal, myotic.
Squinting, discharge, maybe a small pupil. Can it change?
Yes, these sequestra can sometimes remain relatively stable, static for a long period, or they can progress quite rapidly, getting darker or deeper. In chronic cases, the plaque might even start to extrude.
Extrude, like pushed out.
Yes, sort of pushed outwards as new blood vessels grow in beneath it, trying to wall it off or reject it.
Wow. So what's triggering the development of these dark plaques? What causes them?
Well, our sources indicate that the exact cause is still not fully understood. It's a bit of a mystery still.
Really? No clear cause.
Not one single definitive cause, but the prevailing theory involves chronic irritation or ulceration of the cornea that leads to that necrosis, and then a drying out desiccation of the corneal tissue in that focal area.
Chronic irritation leads to dead, dry tissue.
That's the idea. And several factors have been proposed as contributing to this process.
Like what?
Well, those chronic non-healing ulcers we mentioned are a big one. Also, abnormalities of the eyelids or eyelashes, like entropion where the lid rolls in, or trichlesis where hairs rub the eye.
Physical irritation.
Yes. Also, the conformation of those brachycephalic faces, which can lead to increased corneal exposure and incomplete blinking lygophthalmia.
Can't close their eyes properly.
Right. Dry eye, KCS, is another factor. Issues with the quality of the tear film itself, particularly deficiencies in the oily or mucus components.
Poor tear quality.
Previous FHV1 infection, like we said, is strongly implicated. The use of topical steroid medications can sometimes trigger it.
Steroids again.
Yes. And even iatrogenic trauma, meaning injury caused by medical treatment, such as multiple grid keratotomy, sometimes performed for non-healing ulcers.
So it seems like a combination of factors might often be at play.
Very likely. Chronic insult of some kind seems key.
When a vet sees this, what else could it be? What are the differentials?
Important question. Our sources mention corneal perforation with iris prolapse,
Iris prolapse.
where part of the iris, the colored part, might actually be protruding through a hole in the cornea. That can look fleshy and yellowish-brown, sometimes mistaken for a sequestrum initially.
Okay, that sounds serious.
It is. A foreign body embedded in the cornea is another possibility, although these are usually more obviously foreign material. Pigmentation of the cornea itself is pretty rare in cats, and certain types of eye tumors, like a limbal melanocytoma, are also on the list, although these tend to be non-painful, unlike sequestra often are.
Right. Does blood work help diagnose this?
Generally, no. Unlike with corneal degenerations where we might check lipids or calcium, there aren't specific abnormalities that typically show up on routine blood tests in cases of corneal sequestrum.
Okay, so blood tests aren't usually revealing here. Are there other useful diagnostic tests?
Yes, definitely other tests. A Schirmer tear test can be performed to assess tear production and check for dry eye, KCS, though some cats with sequestra can still have normal tear production numbers.
So tear test is useful, but not definitive.
Right. Corneal cultures and cytology can be useful to rule out any secondary bacterial or fungal infections, especially if there's an obvious ulcer or discharge.
Check for infection.
Exactly. The fluorescein stain, of course, is essential to confirm and outline any areas of corneal ulceration associated with the sequestrum.
Gotta stain it.
Always. Vets can also measure the tear film breakup time. This might be reduced, shorter than normal, in cats with sequestra or a history of FHV1, possibly due to a deficiency in the mucin component of the tears.
Tear film stability test.
Yes. And for a definitive diagnosis, a biopsy of the corneal lesion sent for histopathology is the gold standard.
Biopsy confirms it.
Confirms it's a sequestrum and can also help assess if it has been completely removed after surgery.
What about testing for the herpes virus, FHV1?
Well, nested PCR testing for FHV1 DNA can be done, often from a conjunctival swab. However, its clinical value is somewhat limited because many healthy cats can carry the virus asymptomatically and test positive.
So a positive test doesn't prove it's the cause.
Not necessarily, no. A conjunctival biopsy might also be performed sometimes to evaluate the density of goblet cells. These are important for producing the mucin layer of the tear film and can be decreased with chronic inflammation or FHV1.
Goblet cell density. Okay, so how are sequestra treated?
The approach depends on several factors. Things like the depth of the lesion within the cornea, how much pain the cat seems to be in, and practically the pet owner's financial considerations.
Depth, pain, cost. Okay, what are the options?
One option is medical management. This basically involves providing supportive care lubricants, maybe antibiotics if ulcerated, and waiting for the sequestrum to spontaneously slough off.
Just wait for it to fall off.
Essentially, yes. However, this process can take many, many months, and there's a significant risk of the ulcer getting much deeper or even perforating the cornea while you wait.
High-risk waiting.
Can be. The preferred treatment, according to our sources, is typically surgical removal of the sequestrum.
Surgeries preferred. What kind?
A procedure called a lamellar keratectomy. The surgeon carefully and precisely removes the affected layer or layers of the cornea containing the dead tissue.
Keratectomy again.
Yes. This approach usually provides much more rapid pain relief, allows for faster healing, and can help prevent the lesion from extending deeper into the corneal stroma and potentially perforating.
Faster relief, better outcome usually.
Generally, yes. Now, if a substantial amount of corneal tissue is removed during the keratectomy, say, more than half the thickness of the cornea,
If it's really deep.
right, then a corneal graft may be necessary to provide structural support to the weakened cornea.
A graft. What kind?
Various types can be used. A common one is a conjunctival pedicle graft, where a flap of the pink tissue surrounding the eye is moved over the defect. Other options include grafts made from synthetic materials or specially processed tissues, sometimes even donor cornea or sclera.
So patch the hole, basically.
In essence, yes, provide support while it heals. Following surgery, managing any postoperative corneal ulceration is key. So, using broad-spectrum antibiotics, maybe atropine for comfort, and tear supplements is essential.
Post-op care is critical.
Absolutely.
What about specific medications used for sequestra, either medically managed or post-op?
Topical broad-spectrum antibiotics like oxytetracycline or a triple antibiotic ointment are typically prescribed to prevent or treat secondary infection, especially if there's an ulcer.
Antibiotics.
Topical atropine can help alleviate pain and control secondary uveitis, that internal inflammation. Lubricating eye drops or ointments are very important.
Lubricants are key.
Yes, very important to reduce irritation and drying of the corneal surface. They might even help prevent early, non-ulcerated sequestra from progressing further in some cases.
Okay. What about the herpes virus connection?
If there's a strong suspicion of concurrent FHV1 infection contributing, then adjunctive antiviral medications might be used. These can be topical, like cidofovir, or systemic, like famciclovir.
Antivirals if herpes is suspected.
Correct. And there are some anecdotal reports suggesting that topical interferon alpha-2b eye drops can sometimes be beneficial, particularly in FHV1-related cases, but the evidence is mostly anecdotal.
Interferon. Interesting. Anything to avoid?
Yes, interestingly, our sources specifically advise against using topical neomycin-containing antibiotics in cats.
Why neomycin?
Apparently, it can be quite irritating to the feline conjunctiva and can cause a chemical conjunctivitis in some cats, so other antibiotics are usually preferred.
Good tip for cat owners.
Uh,
How often does the vet need to see the cat? Follow-up.
Careful follow-up is crucial. With medical management, weekly monitoring is generally recommended to check for progression, deepening, or complications like perforation as it tries to slough.
Weekly checks if waiting.
Yes. After surgical removal, more frequent rechecks are needed initially, maybe every 5 to 7 days, until the corneal surface has fully healed over the surgical site. Reepithelialization usually takes about 7 to 14 days.
More frequent checks after surgery until healed.
Right, and unfortunately, recurrence of corneal sequestra is possible.
They can come back.
They can, either in the same eye or sometimes in the other eye. Recurrence is thought to be more likely in cats with underlying issues like poor tear production, if the initial lesion was very deep, full thickness, if the surgical removal was incomplete, or if the underlying trigger, like entropion, wasn't addressed.
So important to manage underlying factors to prevent recurrence.
Definitely. And a serious potential complication we mentioned is corneal perforation if the sequestrum sloughs off spontaneously and leaves behind a very deep corneal defect. That's an emergency.
Perforation is the big risk. Okay, so as we wrap up this deep dive, we've really explored the world of cloudy corneas in pets. It's quite complex, isn't it?
It really is not just one thing.
We've seen how corneal degenerations are typically acquired, often linked to other health issues, and involve those characteristic lipid or calcium deposits.
The acquired ones, often secondary.
Then we delved into corneal dystrophies. These are primarily inherited conditions, often affecting both eyes symmetrically, and categorized by which layer of the cornea is involved: epithelial, stromal, or endothelial.
Right, the inherited primary group, usually bilateral.
And finally, we examined the unique feline problem of corneal sequestrum, that dark, plaque-like lesion of dead tissue, frequently associated with chronic irritation or feline herpes virus infection.
Yes, the Keratitis nigrum, mostly in cats, linked to irritation or FHV1 often.
And as we've discussed, recognizing the specific characteristics of each condition, considering the animal's breed and age, and understanding the potential underlying causes are all absolutely essential.
Crucial, yes. For getting an accurate diagnosis and implementing the most appropriate and effective management strategies for these various types of corneal opacities.
Which brings us to our final thought for you, the listener. Given the diverse range of underlying factors we've uncovered today, from metabolic disorders like high fats or calcium issues, to genetic predispositions, to viral infections like herpes, and even physical irritations from eyelids or dry eye,
A whole spectrum of causes.
what might the presence of a corneal opacity in your pet really tell you about their overall health beyond just the state of their eyes? And what further investigations might be warranted sometimes to get that complete picture? It truly is often more than just what meets the eye.
A very important consideration.
Thanks for joining us on this enlightening deep dive.